Right. Because we can save the baby doesn't mean they don't have.
Doesn't mean that their quality of life will be better. Sometimes we do okay, but there's a double-edged sword, isn't there? A question that I may ask would be, the nurse knows that an unintended outcome of technological advances may be
mental retardation.
Could be mental retardation. It could be, yes ma'am.
Favored developmental skills.
Yes, developmental delays. Yes, higher, more complicated patients. That's what you may see on an NCLEX when we talk about how complicated patients are. We're like, patients are staying shorter amounts of time in the hospital, but we still have patients who are more complicated. So even though we can get patients out of the hospital, the ones that do stay there are sicker. So you may hear them talk about more complicated patients. Okay, collaborative care. So we collaborate with a bunch of people. Everybody has their own expertise. What's a question I may ask about this? Do you know whose expertise is what? So for example, nurses, we do it all. We assess, we intervene, we evaluate. That's why I love that thing. Nurse midwives, they deliver uncomplicated births. They're more likely to do home births. Same thing for nurse practitioners. The obstetricians are the physicians who take care of mild to moderately complicated pregnancies. They can take care of a pregnancy with no complications, or they can take care of one that has maybe some mild to moderate complications. But if a person has some kind of complications, you probably aren't going to want to send them to a nurse midwife or to a nurse practitioner. And depending on what kind of complications they have, they may need to see a geneticist. Pregnant people don't see pediatricians. They ain't born yet. And if the baby is preterm, for example, so they are, what's a normal pregnancy?
37.
About 37 to, I think in your book we go with 38 to 42, but about 37 weeks. So if I tell you this woman is 32 weeks pregnant and she is in labor, who are we most likely to consult? Neonatologist.
Yep.
Because we need him to get ready. The baby's coming and it ain't fully cooked yet. If we're having issues with malnourishment, maybe a dietitian. Normal pregnancy, lactation specialist. Every woman, let me say this clearly, every woman should be offered an opportunity to meet with a lactation specialist. Whether it's in her birth plan or not, she's more than welcome to be like, thanks but no, or I'll try it, or hell no. Breastfeeding is hard, and don't let, I really don't like it very much when anyone says, oh, it's so easy, just do it like this, come on, you can do it, and makes people feel like it's, my cousin had a baby, and she had every intention to breastfeed, and she tried, and she was so miserable for like 2 months. It was the worst experience ever, and it affected her ability. It really put stress on the parent-child relationship. Breastfeeding is not for everybody, but insofar as we can support people and encourage everybody to breastfeed, breast milk is best. But just because you're giving your baby breast milk doesn't mean that you have to actually breastfeed. So there's some room to play with that. So for example, if the baby's just having a difficult time latching on, there are other ways to get that baby breast milk. You can express it and put it in a bottle. And if we're talking about, well, they don't get to bond because, well, put the baby on your breast. He doesn't have to suck, but just put him to your chest, bare-chested. It has the same effect. So breast milk is best. Bonding is good, but breastfeeding is difficult. And we need to make sure we empathize about that. Because there's nothing like feeling like you're a bad mom because you can't breastfeed or because you're having trouble. Just about everybody has trouble. So make sure you know where their lane is and how they need to stay in their lane. So high risk versus lower risk and specific risks. Okay, everybody paying attention? This is an important one. we know how many days patients should stay in the hospital and what the general course should be? Yes, ma'am.
Depending on like what happens while they're there, I guess they're like their history or their diagnosis.
Okay, I'd say more their history and their diagnosis, because if they come in high risk, we know there's going to be some complications. But if they come in and have a normal pregnancy, we expect them to go through and have a normal labor and birth, have a normal time in postpartum, and be out the door in 2.5 days, right? Mm-hmm. That's a clinical pathway. There are different clinical pathways for different issues. There's a clinical pathway for normal pregnancy and labor and birth. There's a clinical pathway for women who come in who are hypertensive. There's a clinical pathway for women who are diabetics, for women who have multiple, who have multi-fetal pregnancies, so they've got more than one cooking. And so if, yes ma'am?
And cesareans stay longer, even if the delivery was normal.
That's right. So if it's a planned cesarean section, there's a clinical pathway for that, absolutely. An unplanned cesarean section is something that was not planned for. So that is outside of the normal clinical pathway. That's a variance. So anything that happens outside of the normal clinical pathway is called a variance. It's variance. It varies from the way that it's supposed to go. That's bad. I mean, you know, we don't, variance is bad. Women come in, they're normal, they have a normal pregnancy, they're out the door in 2.5 days, that's good. They come in, they develop a nosocomial infection, that's not on the pathway, that was not a part of the plan. They end up having an emergency C-section, they end up staying 5 days longer, they end up having to have blood transfused, like all that is variance. It costs money, it costs lives, that's what's most important. So we don't want variance. Variance is bad. How do we know that it's that it is variance? It deviates from the clinical pathway. Okay, so what are some questions that I could ask? Basically, I would ask questions where I give examples of variance, or I give examples and I'm asking you to determine if it's variance or not. So, yes ma'am.
Like for someone who had a OB appointment on a Friday and their normal pregnancy weight is 142, and Sunday night she had symptoms of whatever, headaches, and she weighed herself and she was 173. And then when she got to the hospital, they induced her labor at 36.5 weeks because she had then found out that she was preeclamptic. So that's like a variance, right?
Almost.
Of a normal pregnancy, and then overnight it just turned into something like emergent.
Almost, except that variance and clinical pathways occur in the hospital. So if she came in high risk, then that's the clinical pathway that she's on. But if she came in and and she labored for 12 hours, and overnight her weight went up 20 pounds, and now we have to figure out why, and we got to do something about it, and we're giving her Lasix. That's variance. She came in one way, and all of a sudden we've got something that's we're deviating from how she should have continued. So variance happens in the hospital. They come in one way, and then they're on a different clinical pathway. They came in normal, and they ended up on a different clinical pathway. Yes, ma'am.
So like a normal pregnancy in labor at the hospital, pushes for 2 hours, baby heart rate's dropping, mom's heart rate, they do emergency C-section, that would be a variance?
Yes. Yes. Emergency C-section is definitely variance.
So how is variance identified in other places? Like if they're done at home, someone's having a home birth, then what would be, how is it, you understand what I'm saying? Like,
great question.
how is it graded then?
As well.
The point at which the clinical pathway gets instilled, or it gets, not instilled, but it starts, so when do we use clinical pathways? Now, technically, Antoinette, you're right, in that if she was on a normal pregnancy.
I was her, that's why I'm saying it, because that happened to me. I was in normal that Friday, and then I called them, they're like, well, maybe you have swine flu or whatever it was. Then I went in, they're like, okay, you're now considered high risk. Came in with normal readings, but then within an hour, my pressure went to like 211 over 198. So they kept me.
Clinical pathways are executed when people are under continuous care. So home births are a little bit different because you're not in the hospital setting under hospital standards per se, like JCO standards, but when that nurse midwife assumes care for this event or this, and that home becomes an institution of care, that's when a clinical pathway is instituted. Now, pregnancy is a little bit different because you are continuously under the care of a physician, and you start off with a normal pregnancy, and there may be some changes to your health that puts you into a different lower risk or higher risk category. But variance more has to do with what happened when you were in the institution of care, under care, that changed your situation. Sometimes variances, you can develop a variance, like your baby's heart rate the baby can begin to have distress, and now we have to, or here's a better example. You come in, you're having a normal labor, and then your labor stops and doesn't progress, and now we have to induce your labor and give you oxytocin and go in and manually break your bag of waters. That labor induction, that's a variance. We expected you to come in and for you to go through the process and normally, and not to have to intervene in that way. But generally, variances, so let me give you some examples to help you out. Getting an infection in the hospital. Hemorrhaging from a procedure that was done.
Emergency C-section.
Something happens and you have to have an emergency C-section. So something that was not planned. You know, variance is really, the reason why I hesitate is this reason. How do you know what the clinical pathway looks like or what it is?
It's subject dependent.
The facility guidelines. The facility guidelines. And hospitals have clinical pathways that are printed, they are on the computer, they're available, we should access them, they're on every unit. That's how you're supposed to know what's supposed to happen, is you can anticipate, this mom should be going home tomorrow, let me make sure that all of these things have been done. This stuff is, the knowledge is, it's like on-the-job training, because you learn by being in the unit that moms usually go home within 2 to 3 days, but that's just in general. There's an actual clinical pathway that says that. Doctors' offices don't typically have clinical pathways in that way, which is why it's difficult to say that if you change from, if you were not diabetic before and you developed diabetes during your pregnancy, that's variance. That's not variance. It is a change in your clinical status, but variance happens when something unexpected occurs, when it just absolutely shouldn't. So we anticipate that some women may develop diabetes and hypertension just by the very nature of how the body changes during pregnancy. So when you come into the institution of care, that is really the start of the clinical pathway. And so however you define institution of care and wherever that is, and maybe it is dependent on who is giving you care, because you're right, Antoinette, if you were receiving care from a nurse midwife or somebody who was continuously, so for example, if you were high risk and you were brought into the hospital or under somebody's care of high risk and they were continually giving you care, for example, home health care for a high-risk patient, you are now under the care of an institution, and there is a clinical pathway that says how you should progress. Because you are hypertensive, you should progress in this way, and part of that clinical pathway is the potential for you to be on magnesium sulfate. Now, if you hemorrhage out, that really wasn't on the, well, hemorrhage is part of hypertension, so that could be a possibility. If you, while under their care, develop some kind of diabetic issue that wasn't there before, then that's variance, because that's not on the clinical pathway of having a high-risk hypertensive pregnancy. I think what's important for you all to remember for not only test purposes, but also for practice is safety and prevention. Because if you can recognize things early, then we can prevent the emergency C-section perhaps. Or the nosocomial infection. Yeah, variance is bad. And we actually measure variance, which is another reason why I'm kind of careful about willy-nilly calling anything variance, because we have quality improvement measures where we actually, in statistical terms, measure the variance, and Medicaid reimburses based on how much variance there is. So for example, if you are in a hospital that has a lot of variance, a lot of errors, a lot of normal people who don't leave normal, Medicaid is not going to reimburse for those things, and you have less resources, which becomes a cyclic process of under-resourced institutions. But yeah, so we have to be careful about what we call variance. We don't want to call too much stuff variance, otherwise we won't get reimbursed for anything. Hold me accountable. What time is it? Okay. Hold me accountable for being clear, though, because there are a couple of concepts that we're going to go over that kind of overlap. So, for example, there are the maternity goals. That was on the first PowerPoint, or the first slide, second slide. There are the national patient safety goals. There are the standards of care. There are Healthy People 2020 goals. And then there's the Quality and Safety Initiative for Nurses. And those things are different. They have different priorities. They are measured differently, and they mean different things. So one of the things that you're going to need to do for this test coming up, listen to me because this is important, is being able to differentiate which goals and priorities go with which, go with whom. So, let's start at, we're talking about clinical pathways and determining how patients should basically go through. We call them DRG. It's like there's a number. I should go get the book. The Diseases and Disorders book that we have here. In there we talk about the diagnosis, some nursing diagnoses, and then we talk about how many days they usually stay in the hospital and what is the, so if this person with this issue comes in, they're supposed to spend 3.2 days in the hospital, and anything past that is considered variance. That's one way to measure variance. What determines the clinical pathways? Evidence-based practice. If a person comes in with this and we do this intervention, it should work in this amount of time and we should be able to discharge them at this point. So it's based on evidence. So we've got clinical pathways that guide us. We have standards of care that guide us. So the clinical pathways guide how the patient should progress. The standards of care guide what the nurse should do. That's right. So, Joint Commission says what is safe for the nurse to do. The American Nurses Association says what's safe for the nurse to do. The State Board of Nursing, which is governed by the ANA, this is the national body, and each state has their own state body to whom they turn to the American Nurses Association. And if you are in a specialty, so for neonatal obstetrics, gynecology, the Association of Women's Health, Obstetrics, and Neonatal Nursing, AWON, guides you, and they put out practice guidelines. This is what these are the people who tell us that only nurses who have been trained and certified should be sticking their fingers up orifices. So if you're not trained to determine how dilated and effaced a woman is and certified, you should not be doing that. Otherwise, you are outside of your scope of practice, and that is punishable by law. Which is why there are lots of certifications. As a neonatal nurse, I had to become certified in various things. In order to give resuscitation to a premature infant, you need to be certified in neonatal resuscitation. It's called NRP. It's not the same CPR card or CPR certification that you get. This is why people can't just rotate through labor and delivery. Even people who work postpartum and people who work mother-baby, you can't go to labor and delivery or labor and birth and work because you aren't certified in a particular way. So the standards of care guide the nurses' interventions, the clinical pathways guides how the patient should be progressing. So we know how the patient should be progressing, right? And we know what the nurses should be doing to help that along. But we were still falling short for a variety of reasons. So we had to come up with these national patient safety goals. What are the goals for the patient? So not only do we want them to not have any variance, but that is dependent on their specific disease process. This is for all patients. Every patient should get their medication safely. We should be communicating effectively with all of our patients. We shouldn't just go do stuff to them. We need to include them in it. Reducing healthcare-associated infections, falls, pressure ulcers, patient involvement, identification. So these are the national patient safety goals. Just those. Safety, just those. Did one drop off? Am I missing one?
Yeah, medication reconciliation. That's the E.
Medication safety. I may have combined one or two.
Oh, yeah, yeah.
So this says how we are going to achieve national safety, patient safety. The Quality and Safety Initiative for Nurses is called QSIN. They're the ones who came up with SBAR for giving report and improving communication. So these are the 5 things, these are the strategies that we are, as nurses are using to improve safety. This is the bare minimum. Even with this, though, we know that patients aren't always safe. Even when we do the bare minimum of what we're supposed to do, the minimum competency, which is why you take the NCLEX, we have to go the extra step, and that extra step is coming up with specific safety goals and specific strategies on how to improve. So, I may ask you about some specific strategies in here. What is patient-centered care? So a nurse who is focusing on the patient as opposed to her friends or the other nurses working on the shift. So can you identify when a nurse is implementing these strategies or when a nurse is not? Can you identify when a nurse is collaborating versus when they are not, or communicating? Yes, ma'am.
Patient-centered care, do that include their family at all, or no?
It does.
It does.
And I think that's the next slide about the family. The family is very important, especially when it comes to maternity care.
Okay.
Yeah. So that does include the family. In fact, in pediatrics, what we call it is family-centered care. Because if the family is not stable, that child certainly isn't. The quality improvement, that is the measuring of variance and decrease and instituting strategies to decrease the variance. So for example, I'm a clinical nurse leader, certified clinical nurse leader, and what we do is we do assessments, microsystem assessments, so an assessment of the unit to see where the problems are, what the issues are, what the variance looks like, and then we come up with strategies to decrease that. Sometimes all you need to do is get rid of one nurse, and everything changes. Sometimes you need a different process involved. So sometimes you need a whole cultural shift. I was working in a NICU, and I worked in the special care nursery at first, so that's like the step-down unit. There was a big rivalry between the NICU nurses and the ones in step-down. So every time they got ready to transfer an infant from the NICU to the step-down unit, there was conflict, there was lack of communication, nothing got done. The kids ended up staying there an extra week, and this is a Medicaid population. The hospital was absorbing an enormous amount of cost because the kids were ready to go home. None of the teaching had been done, none of the resources had been provided, the kid hadn't had the shots, they hadn't done the apnea study or the car seat study or any of those things, and it's because that information was not conveyed during the shift, during transfer of the patient. They needed teamwork and collaboration. What they ended up doing was collapsing the unit into one and rotating everybody through the step-down portion. So there was no hierarchy of I'm the better nurse, I'm the smarter nurse, you know, you're not worth my time. Communication. So as far as what we'll be using to give report in clinical, it's a great way to talk about what's currently going on. My patient came in, she just gave birth, and her blood pressure, her vital signs are this. So that's usually where you want to start with the situation. What are the vital signs? What's your patient's current status? Now tell me the background.
So what she has,
Now tell me your full head to toe assessment. This is the most critical stuff. She's got these 3 things going on. These are my 3 actual problems going on right now. Here's the background. Here's an assessment of all of her systems, so you know where we stand with everything, and that does include psychosocial, which includes teaching, discharge planning, and all those things that we sometimes forget, and what the recommendations are. So what is the plan of care? So when you get report, you really should already know what the plan of care is for that patient. Now, CYA, you're going to want to double check the assessment data that was given to you. You're going to want to double check the orders, and you're going to want to double check that there isn't anything missing and that she didn't forget to tell you, oh, you need to do these 3 things. So this is the information we want, but we never take things for granted. The worst thing you can do is take report for granted and assume that you got all the information that you needed and it was accurate. You'll learn quickly not to do that. And it's not, sometimes it's on purpose, sometimes it's vindictive, sometimes it is just lack of awareness. It can be lack of experience. Sometimes things are busy and you forget. You can't, nobody's perfect. So always double check. Document on time and maintain HIPAA. Oh, let me go back a second and talk about HIPAA. Because specifically, where's my PowerPoint where I put my notes? Well, let me just say this. I don't want to hear you talking about the patients or the nurses. I have to say that because outside of our clinical conference, so no conversations in the elevator, in the hallways, because you never know whose family is standing in the elevator while you're talking about so-and-so who just had twins, even though you didn't mention her name, and you just talked about how crazy she is, and she was hollering, and you hear her all the way down the hallway, and she smelled a little funky, and like all this stuff. You never know who's watching. And it may not even be a patient, it could be an administrator. And there's nothing worse than having an administrator of the hospital come up to you and say, I heard your students, not my students, the ones in blue, yeah them, talking about a patient and divulging HIPAA information, and I want to know names of all of your students because we're going to follow up on that. And we don't want your school coming back to this institution anymore because we are concerned about HIPAA violations and that we're liable. Seen it happen before. Talk about somebody being upset. It ain't gonna be me upset. It's gonna be Mr. Lewis out there upset. So just be very careful. You never know who's watching. We've already talked about the nursing process. I'm not going to beat that with the stick. We talked about critical thinking. Oh, maybe we haven't. So anticipation. You need to anticipate what could go wrong. What's the worst thing that can happen? It's kind of part of that prioritizing. You need to be asking yourself why. And what evidence do I have to support it? Well, I think that my patient is getting an infection. Well, what's your evidence? What makes you think that? Well, they've got a temperature, you know, I smell their breath, it smells like infection, and got a white blood cell count that's pending, and then we'll see. Evaluating and prioritizing, all of those are part of critical thinking. And this is what separates you from the lay person. We talked about Maslow's hierarchy of needs. We talked about Bloom's taxonomy. I want to talk about it for a second from the standpoint of teaching plans, though, Bloom's taxonomy. So, anytime we are evaluating knowledge or coming up with teaching or learning objectives, this is what we use. So this is why we're using this to test you all's knowledge. But this is also what we use when we need to teach a patient. So let's see here. This is the same thing. This is like knowledge, comprehension, application, analysis, evaluation. Take a patient with diabetes, a diabetic. A woman comes into the clinic, oh, here we go. Create a teaching plan for a woman who develops gestational diabetes and is at different levels of the learning process. So let's say this woman is at the first stage. She was just diagnosed an hour ago. The physician came in, he's like, you have diabetes. All right, I'm out. And now she's left, and she's looking at you like, now what? What is an example of a learning objective for her? I'll start. My first learning objective is that she will list or write or name the normal blood sugar values. I need her to at least know what the normal blood sugar values are before we can go any further. Let me jump here to the next one. So now that she knows what those values are, my next step is I want her to be able to compare the signs and symptoms of high blood sugar and low blood sugar.
Okay.
The next step is I want her to, these aren't good verbs, because I want to use other words, like I want her to, apply. So we want her to apply the knowledge that she has, right? I want her to use insulin or glucose to adjust her blood sugar when she recognizes that it is outside of normal limits. And then I want her to examine if her blood sugar changed relative to what she did. So did she know when to eat something and add sugar? And did she know when to do insulin, or did she switch them up? And blood sugar was 65 and she took some insulin and now she's laid out. She's analyzing her actions here. Did it work? And she's evaluating what her blood sugar is. So I want her to assess if her blood sugar got better and if the intervention worked. So there are levels to the knowledge, to the learning process. So with that being said, the same way that we don't expect you to come out and be able to evaluate when you're doing teaching, you have to remember where they are in that level of teaching. So these are, for example, if you have a new mom and you have some learning objectives for her in terms of how to take care of the baby, you're going to have to start at scratch. She's a new mom. She's looking at this thing. She's like, I don't even know how to take care of it. It's crying. She's like, what do I do? We start at the beginning. Okay, questions, comments, concerns about what we have gone over so far. How do you feel? Tired.
Inspired.
Did you say inspired? Thank you. You keep it up. I'm telling you, I already told you how to work it out, and you keep it up. Okay, childbearing woman. This is my buddy. Watch out now. He's on you. That means you're the first test I look at. After that, I'm like, how you do? Okay.
All right.
Thumbs up. No. Okay.
Yes, it will be thumbs up. Yes, you can keep that face.
I know that's right.
You can keep that face.
Now, we were going to watch a video about cultural sensitivity, but we can't get the video working at the moment. So just know that we need to be sensitive. And if we have some time tomorrow, maybe we will do a little activity. In fact, yep, let me see where we are. We may do it. Families come in different shapes and sizes. Here's my question for you.
Ariel,
Oh, yes, ma'am.
where's this part at in the book? Everything we're talking about, I see in the book, but I don't see like the childbearing woman.
Chapter 18.
Oh, chapter.
It's not only one chapter.
No, this covers chapters 1 and 18. Yep. That's on the schedule, right? Is it 18 or 19?
18.
18.
1 and 18.
Somebody have a page number for us in chapter 18 where it talks about families? 150.
355.
355. Here's the question I have about this. Which family is most vulnerable? Which family type is most vulnerable?
Vulnerable to what?
Poor health, poor outcomes, poor maternal child outcomes.
They all face the same thing. But I would say
It is a trick question. I'm so proud of you. That's great. Yeah, no, just because you have a different family structure doesn't mean that you are or more or less vulnerable.
so the
Because
same standards are proper.
you could be a single parent and have a whole host of aunts, uncles, brothers, sisters,
Amen.
cousins,
Well.
grandmoms, granddads. I mean, it's a daggum commune that you live on. But you could have a nuclear family and have only the 3 and no support system other than the 3 people in that nuclear family. So what makes a family vulnerable is the level of support and access to information, resources, and access to information and resources and support. That's what differentiates vulnerability. Not your gender, not
Not none of those.
there it is.
None of those.
Because they can all have the same commonalities.
Access to support, resources, and information. So we kind of touched a little bit about on family-centered care and how the family is the individual is a part of their family. And so it's important to think about the family and also the differences in cultural beliefs. But what's important is to recognize when the cultural belief poses a risk or a benefit. For example, well, I'm going to let you all do that. So we'll keep going. We'll come back to that in a second. Prenatal care is important. You don't get to watch the video, but
God bless you.
home care. So we talked about care like from an institutional setting where you go to the hospital, you're at the doctor's office, so forth. But we're also kind of moving to this model where a lot of the care takes place in the home. Yes, ma'am.
Sorry. I'm not seeing this in chapter 18. Is it another chapter? Yeah, I just want to.
Oh.
I'm looking.
Yeah, we get to the adolescent stuff tomorrow. It's chapter 18 I split up between today and tomorrow. This is actually the last page of chapter 18. And remember, if it's not on your PowerPoint, then you're not, I would not focus on it as a priority for the test.
Home care? No, I got it.
It's on page 366.
Page 366.
I think.
So there is quite a bit in chapter 18 that you all will be responsible for the test, but all the adolescent pregnancy stuff is tomorrow.
68.
68.
Page 68.
Home care?
368. 368, okay. So you do need to know the priorities of home care for each of the different time points because they're different. Prenatal is about fetal health assessments, maternal and fetal health assessments, so we can identify any potential problems. We're helping to prepare them for the birth of the child and child rearing. In the postpartum period, it's about healthy adaptation. So is the newborn adapting to its new environment? Is the mom going back to her normal physiological state? And how is she coping with, psychologically, with the changes to her role function, her body, and as well as the different hormones that helped her birth the baby and recover. So normal newborn adaptation is not a priority of prenatal care or high-risk prenatal care because the baby's not born yet, so think time frame. And also think about high-risk care. So this is high-risk postpartum care, because if someone is high-risk prenatal, where should they be cared for? In a hospital by a neonatal, by at least an obstetrician and perhaps a specialist, a maternal fetal specialist. But afterwards, high risk. Once we send the baby, we can send babies home and they're a little bit high risk. These are the kids who are on phototherapy at home, and I don't mean like we're sticking them out in the sunlight every now and again. I mean like they've got the blankets, they're glowing. Blue blankets. They may be going home on apnea monitors. So this is a baby who maybe spent two months in the NICU, but they're still having periods where they stop breathing, so they're on an apnea monitor. They're getting caffeine once a day to help them remember to breathe. And we expect that to maybe last for a couple months. Failure to thrive. So a kid who's not gaining weight may need some continuous care. And women who are homeless need more resources because they are not in a safe environment, so they're more at risk for safety issues, which poses a problem for helping them access care. If they're homeless, we don't have a home where we can be providing this home care. So, questions about what maternal home care looks like? On the prenatal side, it's low risk, but we do some high risk for babies at home after they're born. But really just these three things. Anything more than that, and that's. Yes, ma'am.
What's the difference between apnea and periodic breathing in babies? Like, how can you differentiate that?
That's a good question. So I think the clinical definition is that apnea lasts 5 to 10 seconds. And periodic breathing means that periodically they will go maybe 3 to 5 seconds without taking a breath, because babies breathe fairly fast. So if they're breathing, babies breathe 40 to 60 breaths a minute. Newborns anyway. The older they get, the slower it slows down. So we're talking about a breath a second almost. So 3 to 5 seconds. They may have some periodic times where they have this periodic breathing as they're transitioning, and it should really only happen in the transition period. They shouldn't be breathing normally and then start and develop periodic breathing. That's going backwards. That's the problem. But apnea is when I believe it lasts 5 to 10 seconds. So it's the length of time. Because 5 to 10 seconds and the baby's lips have already started to turn blue a little bit.
Okay, thank you.
Questions, comments, concerns? Okay, let's take the last 15 minutes of class and take a look at, it's in chapter 1, page, there's a chart that talks about the different cultures and their practices. Now, we know that this is not a prescriptive, what page are you on?
13, 12?
Is that it? No.
12, 13?
What is it? There you go.
12 or 13.
12, pages 12 and 13. So we know that this is not prescriptive, and that you need to ask people what their practices are, but it's good to have some general knowledge in case you see something, you witness something, and you're like, they are beating that baby to death, and really they're just cuffing. Or why do they have that baby swallow so tight he can't breathe, but really it's just the way that they create security. So there are some things that provide benefit, because swaddling the baby tight, that actually provides a sense of security for the baby. And so that's a good thing. But there are some risks. some practices that could potentially be risky. So it's important that you identify what those are. And for the last 15 minutes, I would like you all to get into groups of 4. So wherever you're sitting, talk to your neighbors, and identify what are the benefits and what are the risks. If it's a benefit, you may want to highlight it, but what's most important would be the risks, because that's probably what I'm going to ask you about. So I may say, a woman of this ethnicity is doing the following behavior. Which of the following responses by the nurse is best? If it's one that creates a risk for the kid, then we need to be intervening. If it's one that doesn't create a risk and may even provide a benefit, then we should encourage the continued cultural practice. But you need to know which ones are risky and which ones are not. So, everybody look for a moment. Okay. There are 1, 2, 3, 4, 1, 2, 3, 4, 5 groups. You all will do Hispanics.
Okay.
And you need to do this and kind of jot this down, because we're going to start off tomorrow discussing what the risks and benefits were for each group, so that everybody gets a chance to hear what some of the risky things are for every culture that's in here.
We need the European culture. Why are they always missing?
Where do Europeans go?
Didn't makes a good point. Let me go ahead and assign these, and we may have to start off with this on tomorrow, but this is an important exercise that I want you to do. But Dennett just brought up a really good point that I'm going to take a moment to get on my soapbox and talk about in just a second. Hispanic, Asian, Middle Eastern, African American, Native American, Hispanic, Asian. Are you all? All of us are Asian? Yes. Yep. There you go. Okay. What Dina pointed out was that there is no. Yes, ma'am. Oh, sorry.
With the Middle Eastern, right? Because we have this on the test. Are they considering that under Muslims? Because we had that on the test and they made it the same, even though Muslim is a religion, not being Muslim.
And not all Middle Easterns are Muslim, like not even close.
Yeah, so that's why I wanted to know, like, for a test question, would you put Middle Eastern or would you put Muslim?
I'm going to use what's in your book, and I'm going to put Middle Eastern. And I'm going to try to be very careful about that on my test, and I can't say about the NCLEX, and which goes to my point about this. Do you notice that there's a group missing? I didn't notice it. Swear, this is my first time even recognizing it. I'm not surprised. Do you notice that there's a group missing? Caucasians. Why? Because they are the norm and the standard by which everybody else is measured. That's called ethnocentrism. I messed it up. That's called ethnocentrism. Ethnocentrism. It is pervasive. It is the dominant culture, and we need to resist it. Because not only does it make all those groups on that page the other, but what it does is it doesn't even give us an opportunity to recognize Caucasians or European Americans or Italian Americans or whatever the ancestry is as a cultural group that may have a specific set of cultural practices. And in fact, in recent literature, there's been some books about race that have been out in culture, and the criticism is that it's a double-edged sword. Not only does it other minority cultures, but what it does is kind of turn white culture into an acultural group. And that's not true. Everybody has a culture. Everybody has a culture. And so I just thought that was interesting, so I'd point that out. I do help equity work, so that's really important to me. Yes, ma'am?
We do Hispanic.
But when it says that I'm African American under during the birth, it says Muslim women, but over here it says Middle Eastern. I'm confused.
So are they, girl. So are they. I mean it. I'm serious. So are they. So are they. And not. What does it mean to be African American? Because now living in Philadelphia, there are a lot of darker colored people who do not identified with the Black American experience. They're Haitian, they're Jamaican, they're from the islands, they're from Africa, they're from wherever. They may have been born and raised here and grown up here, but people are mixed. People are, you know, I came from I spent a lot of time in San Antonio. I like to identify a little bit as Hispanic. To be quite honest with you, I ain't got a near bit of Hispanic blood in my body. I mean, I guess I could pretend. But I ate enough, you know, Spanish food. You think that count? I don't know. The point is, you are what you say you are. You identify with what you identify as. And just because I look one way doesn't mean that I don't identify with Asian culture. For example, my cousin married an Asian man, and they are raising their child Asian. And so she identifies with an Asian culture. She had an Asian wedding and all of that. So to expect that just because she looks a certain way, that she doesn't identify with all things typically Asian it's not fair to her. So we should always ask and not make assumptions. But we are looking at these practices because if you see them, I don't want y'all to be like, oh my gosh, let me go tell my instructor they ain't here killing this kid. I'm just like, no, it's okay. It may be risky, but it's cultural. Let's figure out how to
If it's cultural and say, okay, so where are you drawing the line?
So you're going to identify the benefits of some of those practices, but most importantly, you need to identify the risks. That's what I'm going to ask questions about. And what are the appropriate interventions? If it's risky, you better do something.
Yeah.
I think this is the best. I don't know. Cool air morning.
Oh, yeah. All right.
Okay, for the nutrition,